Honorable Chief Minister Sindh, Minister for Livestock and Fisheries, Sindh, and Minister for Livestock, Balochistan, and Minister for Fisheries, Balochistan, distinguished guests, ladies and gentlemen, Assalamu alaikum. So this is a short presentation of the departmental activities.
And our primary healthcare system is not built for the CDs and NCDs and not for, rather for maternal and child health. So let's move on to Dr. Asif Imam. So in our mixed health system, NGOs and CSOs have been filling up a major gap in the primary healthcare service provision. You, sir, have been the pioneer of utilizing an NGO platform for delivering quality primary healthcare services through the SINA initiative. What are the challenges and the successes for CSOs and NGOs to deliver universal healthcare in Pakistan at national as well as provincial level? Or what innovations or intersectoral collaborations are needed to engage the NGO sectors to achieve these SDGs? And what is the public policy vacuum in engaging the private sector for UHC and primary healthcare?
Thank you very much. My name is Asif Imam, and although I'm an allergy immunology specialist, but my passion is primary healthcare. And actually, I moved from the US to set up a robust system of primary healthcare. So, as we all know, WHO says that 80 to 90% of healthcare needs can be met at the primary healthcare level. And if you look at Pakistan, we're just the opposite. We don't have any primary healthcare system at all. That's where the fundamental problem is. And this is what we need to address, that our foundation is actually not good. We don't have a good primary healthcare. The good news is that PMDC's new leadership, they have actually sort of revolutionized the thought process of what a good primary healthcare system should be. And they are now totally focused on primary healthcare. The leadership has understood that primary healthcare ke baghair kuch nahi hoga. So right now, PMDC is trying to revamp the curriculum in which the training of the graduates, postgraduates, because there was no primary healthcare training post-medical school. Everyone was training in the hospitals. And obviously, as you know, hospital training and the primary healthcare training is very, very different. So now what they're doing is they are mandating each medical college not to just open a hospital, but 5 primary healthcare centers for training of the students and residents. So this is revolutionary. So the trend and the intellectual process has already started. But the problem is that is the first step. So you have to change the curriculum, emphasize on primary healthcare, which will cater to 80 to 90% of healthcare needs in Pakistan. If you look at any effective healthcare system like NHS or the Canadian system, they have a very robust primary healthcare system. And this is where we need to focus and develop. So the SINA story starts in 1998 when I came back from the US and started to understand the primary healthcare system in Pakistan. And obviously it was very obvious that we need to develop a whole system, not just do things in silos, complete system. And we presented our model to the WHO EMRO region in August 2023 as a care model of a primary healthcare. And it was well received over there. And since actually before we presented it, WHO has actually come up with 10 levers, operational levers of how a primary healthcare system should work. So what we have done is we have taken that 10 levers and we have developed our systems according to that. And I think we, out of 10, 9 of us, we can actually claim that we are doing that. So I think the first thing is you need a very robust model or a system with training. The good doctors are trained in that system. The second challenge was you can have a nice infrastructure, a nice clinic, and the nurses, but the nurses and the doctors are not trained for primary healthcare. So we have to revamp the training as well. And this is a very big task. This is something that I think our PMDC is starting to do, but I think even the medical colleges and the residency programs should start doing. So the system is number one. Second is training of the multidisciplinary approach. Like we all said that our system is doctor-driven. It has to be multidisciplinary-driven. The doctor cannot do everything. They need a support team to support and provide the proper care to the patient. So training ke baad, basically it comes on implementation of that system with accountability. So हमारे वहाँ ये होता है कि आप डॉक्टर को आपने या नर्स को आपने एम्प्लॉय कर लिया and then कोई पूछता नहीं है कि उसका परफॉर्मेंस कैसी है. So this is something, accountability has to come. Until accountability comes, don't expect any kind of quality of care. So we have worked on that in our system also. We have started with the audits of the doctor performance, and we have a very robust quality performance audit system for the doctors, and we re-educate them. If they have any shortcomings, we train them. That's the third thing. The other thing is, this is age of digitization. We need a very robust 360-degree digital platform which will integrate all kinds of care. So we are in the process of developing a multidisciplinary digital platform, especially for primary healthcare, in which the doctor, the nurse, the nutritionist, the physiotherapist, the social worker, the pharmacist will have their own domains in which they can put their documentation of what kind of care they gave to the patient. So we have to move on to the modern technologies. And once we have done that, then we should work together, and then we come up with a national standard, like NHS. See, NHS is a national standard. We should work together, all the academic institutions and the NGOs and the private sector. They should come up with a national standard of primary health care. And then things are going to start happening. So that's my 2-bit.
Thank you so much, Dr. Asif. So a shift from the doctor-driven current model, accountability, digitization of services, and as we have gone through 4 of our panelists, I think all of them are agreeing that although there's 5 years left till 2030, but the primary healthcare has huge amounts of lacunae, and we are all aware of it. So we can definitely shift towards device policies to address them. Next, I move on to the primary healthcare systems, the public primary healthcare system specifically, and the maternal and child health services. So, Mr. Javed Jagrani Sahab, who is the CEO of the PPHI, you have successfully expanded and improved the PHC network in Sindh, especially for the maternal and child health services. Please, can you share the public partnership model, this particular model, how it has evolved in Sindh, and how do you think that this model can be leveraged in our mixed health system to achieve the primary healthcare and universal healthcare coverage goals?
Thank you very much. Thank you very much. Yes, as far as PHC it is concerned, with the perspective of this PPP mode, basically this public-private partnership, that's maybe if not that much new, but in the recent past, it's a new type of management model which has achieved good results in different sectors. So with this approach, government of Sindh applied this. Initially, federal government, all of the provinces, and then Sindh government, specifically in Sindh province, they adopted this approach in health sector and particularly in the primary healthcare side. So it really has brought good results and good fruits as far as primary healthcare is concerned, because I'll just briefly touch upon why it is so, because it is addressing system issues, basic issues with which our governmental public sector system was stuck up with. why it was not delivering, why it was health facilities in far-flung areas were not delivering. So it basically this new model whereby PPHI is working under an MOU with the government of Sindh, it addressed those core issues which were inherent in those public sector health facilities. Number one, financing model. The government of Sindh came up with under this PPP model. We have a different financing model whereby one line grant is given to PPHI. It is PPHI who has to decide, who has to prioritize funding allocation. Before this, it obviously was different model, and prioritization was not being done. So this solution, this one line single line grant, really gave a space in terms of prioritizing the areas, geographical areas, services areas where by a true delivery can be done. Number one. Number two, then administrative independence. These were the two issues which were inherent, as I told you, as far as primary healthcare facilities were of concern of government of Sindh. So when I say administrative independence, here PPHI is totally independent to take administrative decisions in terms of HR hiring, in terms of aligning services with the modern day, approaches and all that, which was missing earlier. So with these few but basic inherent issues addressed with this PPP approach, obviously there has been a topsy-turvy change as far as PHC is concerned. Once I share the results, I have maybe data when PPHI started some around 14 years back, few of health facilities were handed over by government of Sindh for its management, and right now the number is 1400 plus, which means in terms of the coverage, we are managing 40% of primary healthcare as far as population is concerned, the whole of the Sindh. And in terms of rural Sindh, we are covering more than 60% of primary health coverage. So we basically came up with a new idea with same issues, and the coverage is day by day increasing. Geographical coverage is increasing, whereby PPHI is operating in all far-flung areas of province of Sindh. Maybe it's tough areas, hard areas like Kashmir, Tharparkar, Kambar district. So we are everywhere in the whole of the province. In terms of financial coverage, analyzing services being given by PPHI vis-a-vis UHC, this is another important component of UHC, that in terms of financial equity, financial facilitation, the UHC services have to be provided, keeping the financial position of the patients also. So in their terms, PPHI is providing 100% all the services free of cost, which means addressing this particular issue of UHC. In terms of services coverage, we are focusing upon all the indicators which are covered under universal health coverage, all the priority indicators, which happens to be 30. In majority of the indicators, the PPHI is providing a comprehensive and 100% package, which happens to be around more than 40 to 45%. Around 30% of indicators we are giving partial services, and there are still 15 to 20% of indicators as far as UHC is concerned, whereby PPHI is not providing those PHC services. And obviously it depends upon government of Sindh. We have taken up this particular case with the government of Sindh so that a comprehensive package of UHC is provided to the population of government of Sindh. Having said that, the good thing is we have, government of Sindh has piloted one project at Tandu Alayar, whereby a comprehensive EPHS project and package has to be given at Tandu Alayar. That will be pilot, and the target is that the UHC coverage in terms of essential package of health services has to be comprehensive. All those indicators, the priority indicators in terms of service delivery at PHC health facilities has to be, the target is that all those priority services are given to clients, to patients at the health facility level. So this is really a good start, whereby we are going to digitalize services. We are making the service package more comprehensive. So in winding up my discussion, I'll just say that obviously this PPP this novel approach has worked as far as primary healthcare is concerned. Number one, number two, more efforts are required. Obviously, if the package has to be comprehensive in government, and we are negotiating with Sindh government. More health facilities, maybe 100% of primary healthcare health facilities have to be given to PPH, and once that is done, hopefully this whole USC package will be comprehensive in Sindh. Thank you.
Thank you so much, Avit sir. So administrative independence that comes with the public partnership model has been very successful in Sindh, and if we look into this model, it could possibly be something which we can utilize, and other provinces can also utilize this model, which is solving some of the key issues and being able to administer the 3 pillars of the universal health coverage. So for the second round, we have identified all these problems, and I think we are all agreeing to it with all your expertise. We all know what the problem is. Now, if you can all just give us 2 to 3 solutions or recommendations, what should be the direction of working now in this time constraint of 5 years, trying to achieve universal health coverage through primary health care? Just 2, 3 recommendations from each one of you. Sir, Apsitar.
Thank you. One thing I think we must keep in mind is that universal health care is not a luxury. It is right of every child that is born, irrespective of caste, creed, or pocket, or whatever. So far, whichever model you look at, private-public model in Sindh, this is not really a private-public model. It's more of a philanthropy-driven model. That you have people, because there are more industrialists in Karachi and in Sindh, and there are very, very rich people and too many poor people. So there are very good people who want to donate something for the base of the pyramid. So that is being, I think, used. But if you go to the rural Sindh, which I have myself gone to rural Sindh many times, I think the coverage there is, nowhere near that we need to be. I think the universal health care in Punjab, they have tried to outsource it to the private, and they failed miserably. One thing the government must realize, or be made to realize, is that it is the responsibility of the government and not anybody else. So you cannot, provide universal health care or optimum health care to people with charity. Charity is add-on. You cannot shift your entire burden of your duties to the philanthropy center. You can only thank them for doing what they are. But they are not responsible. It's the government who is answerable to the people in what they have done. Unfortunately, I think what needs to be done is that we do have in Punjab, and I am in Sindh, rural health center, basic health units, but most of them are dysfunctional. They need to incentivize the human resource for health to go into these rural areas. Then they need to pay them double or maybe triple of that. So they need to populate that. Those buildings are now being used as, somebody has started a school there, or somebody. So they are not really functional at all, majority of them. So I think to make them functional, the main bottleneck is the human resource for health in these far-flung areas, the security issues, which again it's up to the government to sort out there, and then non-functional equipment there. So and then the provision of medicine is not there. So that needs a good governance model. In Punjab, we have a model where primary health care is separate and tertiary care is separate, specialized care. It didn't work. I think it was much better when we had one health department. The most important thing I think that needs to be done, and during my tenure as a minister, we started that, is the referral system. If you have a referral system where you have catchment areas with your tertiary care hospital, the teaching hospital, and then because they are also public sector organization, then shift the duties to them to make sure that there is adequate human resource for health, like for universities, medical universities, health universities, or for the medical colleges. We did a pilot where we attached few districts to a particular medical college, like Allama Iqbal Medical College, and then the consultants were going there weekly to the basic health units, and even surgeries were started and everything. But as always, once the government changes, everything changes, unfortunately. So there was no sustainability, but the pilot did very well. 2 years pilot in these districts, Saiwal and Okada, attached to one medical college, and that improved the situation there, the vaccination rate, the nutrition, which is a problem in children, as Khalid Shafi just highlighted. And these things, our problem is there is too much overcrowding. For example, I have been chief executive of about 12 major hospitals like PIMS. In PIMS, which is a university teaching hospital, we were doing 250 plus deliveries every day. So we are not a maternity home. So that is why I think the people look up to these tertiary care hospitals, because there are non-functional facilities next door. So that they need to be made functional.
Thank you. So 2 minutes में what should we do? क्या करें? 2 चीजें 3 चीजें क्या करें?
I will just add to what Dr. Javed has mentioned. Actually, our priorities should be focused toward the prevention. That is the only way we can get the universal health coverage. And the missing part is that all the attention is on the curative medicine. Even preventive medicine is not much taught as it should be in the undergraduate and the other curriculum. And in the primary health care, the missing part is the community engagement. And the community participant is still in the places where it is practiced. The community engagement is not there. In the Azad Jammu Kashmir, the community engagement is so strong that their 85% vaccination is done at the vaccine centers. The community is so bound that they do not miss any vaccination. Their coverage is more than 90%. But in the other parts, it is only 30% vaccine is done at the fixed center, while the immunization vaccinator has to go door to door. So it's a community participation which is an essential part of the PHC.
Right.
It should be promoted. That is the way we can get good results.
Ji, Dr. Sobia, 2 things we can do.
I think the key is the prevention, and we have to start with prevention if we really want to have universal health coverage with VHC. And the prevention has to start from the school-based trainings, nutrition, vaccination, and just from the grassroots level. Secondly, build up on the frontline workers. So we have lady health workers who are generally giving population control advice or gynecological services. They can be upscaled to screening for diabetes, for hypertension, for obesity, because these are the rising threat of non-communicable diseases. Then better data and digital tools. I think it is the area of digitalization, and without electronic records, it's not possible to make our policies. And finally, I would say proper referral between the primary healthcare hospital and the hospitals. That needs to be smooth and recognized.
Ji, thank you so much. Dr. Asif, what 2-3 things we can do?
Ji, I think if you really look at the theory, it is very simple. The problem is implementation. That takes time, money, and all that. So I think यहाँ बैठ के we can say कि ये कर लें वो कर लें, but I'm afraid it's not going to happen. So I'll give you this simple, actually very straightforward principles, especially on the primary healthcare. And this is what I've basically learned from the WHO and working in the field. So you start at the basics. Our model of care is flawed. We need to develop a multidisciplinary, patient-centered, preventive model of care. Now that's very simple to say, but doing it is very, very difficult.
Sure.
So a model of care, we need to come up with a model of care which the private and the public sector agrees on and say, okay, this is what we want. Right now we have multiple models of care, and that's not going to work. Second is training is the key. If you have a system and you put in the current nurses and the doctors to run that system, it's not going to work. So you need a very robust, multidisciplinary
At Badar Expo Solutions, we are committed to connecting people, creating values, and delivering impactful events. Our mission is to make emerging healthcare trends and innovations accessible globally, while fostering meaningful B2B matchmaking opportunities between local and international stakeholders.
हेल्थ एक्सपो एंड कॉन्फ्रेंस लास्ट ईयर हमने शुरू की, इस साल इसका सेकेंड एडिशन है. अगेन इसे एक बहुत बड़ी मैं सक्सेस समझता हूँ कि पहले सेशन के बाद हम दूसरे एडिशन के ऊपर आए.
Your vision and dedication in promoting Pakistan healthcare industry through such high-level platform is really commendable.
Let me start by congratulating Mr. Zohair from Badar Expos and the spirit behind Abid Abbas Sheikh Saab for arranging such a beautiful conference.
ये सिर्फ एक नुमाइश या एग्जीबिशन नहीं है, ये एक सोच है, ये एक सफ़र है जिसकी बुनियाद डाली जा रही है. और हेल्थ केयर एक ऐसा सब्जेक्ट है कि इसको समझने की और इस पर अमल करने की ज़रूरत है. तो मैं ज़ोहैर नसीर साहब आपको और आपकी टीम को बदर सोल्यूशन को खराज तहसीन पेश करता हूँ.
Assalamu alaikum ji. I'm really grateful to the organizers for having this very important session on patient safety. Something which is very close to the heart of everyone who is concerned with medicine, deals with medicine, either in the form of a professional doctor, a medical professionalist, or regulatory bodies like DRAP, or those who are in the process of making medicines like from the pharmaceutical country. So a very important factor which involves all of us equally. So patient safety is one thing that we feel and I personally feel, is not given that much significance and importance in our country as it has been given to anywhere else in the world. So at times, I myself being a practicing surgeon, I know when I was working at the JPMC General Hospital, or later on I'm working in the private sector now, the patient safety does not come as one thing that we should be taking care of as the first step. And that is what we want our new generation of doctors who are coming up, that they should be aware of that. So a panel which represents almost everyone from physician, Aftab Sahab, from surgeons, to those who are in regulatory bodies, from PharmU, and those also who are from the hospital side, like Nashwa is from the South City Hospital. So let's start. I'll start you, sir, Aftab sir. What structure and cognitive factors most commonly contribute to the diagnostic errors that we make? And there are a number of diagnostic errors we all know. And how can healthcare team, not an individual, proactively mitigate them? What do you think? What do you think how it could be done?
I think the first thing to do would be to define diagnostic error for the sake of the public. And diagnostic error means when you cannot make the right diagnosis, or you miss the right diagnosis, or even if a diagnosis is delayed, that is also called a diagnostic error. And if even the diagnosis is correctly made, is made in time, and is not communicated to the patient in time, even that is a diagnostic error. So in US, about 12 million diagnostic errors took place 2 years ago in 1 year. And they were responsible for a number of deaths. Diagnostic errors, they come under the ambit of medical errors. And the medical errors were first highlighted in a report of Institute of Medicine, which was published in 1999. So I personally believe that these occur because we do not do what Sir William Osler asked the modern day physician to do. And he was a professor at University of Pennsylvania in 1905, beginning of the last century. And he said, listen to your patient. He is telling you the diagnosis. So unfortunately, we are more focused on clinical decision support systems and artificial intelligence, whereas in many prospective studies, we know that the correct diagnosis can be made in about 75% cases on history alone, 6 to 7% on examination, and 13-14% on investigations. So if we employ the right history, spend quality time with the patient, examine, and become a thinking doctor. One important thing is, as we become senior, we stop at times to think and do things reflexly. And that contributes to diagnostic errors. Once the diagnosis is incorrect, then it erodes the trust. It jeopardizes the outcome of the patient. It causes extra burden on the cost. Medical errors, sir, are responsible for an additional cost on healthcare of $50 billion per year. So this is all preventable if we start with the right history, spend time with the patient, and if we have systems in place. Unfortunately, when we are overburdened with patients, we do not have systems. So first is the cognitive problem, that the physician herself or himself is at fault. Then are the systems. अब वो हमें कहते हैं कि जी EMR, electronic medical record होना चाहिए. आप बड़े-बड़े ओहदों पर रहे हैं माशाल्लाह, and you have headed so many institutions, and now you are at the helm of the policy making in the province of Sindh, and with the status of a minister. So you should know that these doctors, EMR requires time. If you go to US and UK, a doctor is supposed to see only a maximum number of 10 to 12 patients in one day because it takes 30 minutes to register the patient on EMR. तो एक तरफ expectation है कि EMR हो, दूसरी तरफ number of patients ज़्यादा है. फिर हम जब मांगते हैं as a physician sir, we ask for a data entry operator, तो वो कहते हैं नहीं ये आपने खुद करना है. तो बड़ी ही एक dilemma है. फिर दो चीजें और हैं with the permission of the chair, I would like to highlight जो diagnostic error में significantly contribute करती है. एक है health disparities, और आपसे ज़्यादा कौन aware होगा कि जब मरीज आता है हॉस्पिटल में तो वो लोग जिनको सबसे ज्यादा जरूरत होती है केयर की, they end up receiving the least care. I will highlight few examples. People who inject drugs, doctors, most of them look down upon them. ऐसे जैसे वो कोई जुर्म करके आ रहा है, वो तो बेचारा ड्रग एडिक्ट अपनी मर्जी से नहीं हुआ है, वो तो आपकी शफकत और मोहब्बत चाह रहा है. People who are left unattended, people who are poor and marginalized, people who are mentally challenged, people who are old and who have multi-morbidity, ये सारों को ज्यादा जरूरत है. और प्रिजनर्स, लेकिन इनको कम मिलता है. तो एक ये भी वजह है डायग्नोस्टिक एरर्स की और मेडिकल एरर की. और सर एक और वजह वो है ये सिस्टम कोई इंसेंटिवाइज नहीं करता. अगर कोई अच्छा काम कर रहा है या बुरा काम कर रहा है, वो सबके लिए बराबर है.
Dr. Naveed, continuing with what Aftab sir ने बताया in a very, very nice, elaborative way, what errors are. Don't you think, as he has said, that right now we are emphasizing more on the diagnostic tools rather than applying our knowledge of medicine in the form of history taking, examination, which our professors used to emphasize a lot. And they were of the view that, as he has very correctly said, that majority of the diagnoses are made on that. Today, हम या हमारे साथ जो लोग हैं, because of the availability of CT scan, MRI, so many things, the first thing we do is when the patient comes with a, for example, a headache, MRI करा के आते हैं. Now taking an easy way out to diagnose because we have got so much rush, we don't want to examine him properly for that. आप क्या समझते हैं? Does it contributing to diagnostic error, and how can it be overcome?
Sir, thank you very much for giving me a chance to elaborate myself on such an important topic. So you are very right, sir. Said a very important sentence in the beginning that listen to the patient. He is telling you the diagnosis. So I personally feel that one factor is the patient's workload, because a doctor has to see a lot of patients in 3 to 4 hours, and the patient expects that the doctor should not only listen to him or her, he should also examine her and him and then prescribe the relevant investigation. But I personally feel, sir, keeping in view all these limitations, they are there, but one link is definitely missing, and that is we do not touch our patient. That sense of touch, like we talk of the sense of touch between the mom and the baby, exactly the same relation exists between the patient and the doctor. This link is missing, and how we can re-establish this link, I don't know, because the patient to doctor number is too much. But I personally believe that this factor should be addressed seriously, and this should not only develop the patient-doctor, strengthen the patient-doctor relation, but it also decrease the workload on our investigations. Like, number one, the patient expects a doctor साहब को test ही लिखा, so doctor writes the whole battery of the investigation, including chemistry and radiology and everything. But if we start doing that, and if we start developing the rapport with the patient in terms of detailed history and clinical examination, and then full explanation to the patient, because once the patient leaves the office of the clinician, he's I don't know, मुझे तो नहीं पता डॉक्टर साहब ने कि मुझे क्या मसला है. So we should properly explain the patient, and it would definitely decrease the workload on our investigation to better investigation. As sir mentioned, I was reading a few days back, because it would also jeopardize the number of patients, it would also jeopardize the patient safety as well, which is our prime topic today. And recently I was reading an article in which it was mentioned that the number of deaths in USA, because USA and UK, they are the icons for us. We read the books written by their doctors, and it counts around 2 lakh a year because of the breach in the patient safety chain. And number two example of UK, the NHS budget rose almost to 40% in the last 1 to 2 years. So I personally believe, sir, highlighting the very true topic of this age. The number of patients is the main cause that our diagnostic battery of investigation rate is rising, and we are missing the link between the patient and doctor because we cannot explain to him, we cannot examine to him.
Samad Sahab, ये बताएं कि because you are in digital, which is the latest thing like AI and other things the companies, do you have any solution for the problem that has been raised for overcoming these diagnostic errors? Do you have that? Not only relying upon the diagnostic tool, because once the tool goes wrong, the whole management will go wrong. So, do you think that the recent trends that you were just talking about, bringing up together, can they be of any support in overcoming this decision making of a diagnostic tool not to go wrong?
Assalamu alaikum. Thank you so much, sir. First of all, we at Digitrends currently working on the AI solutions which we think can make a difference in patient safety. I will give you for example which I think is relevant, how AI and IT can make a big impact on patient safety. First of all, we are going to integrate it with our EMR solution. So currently in the conventional EMR, if doctor enter the wrong medicine, or if any medicine which is not suitable for the patient, he has the allergies or some kind of histories, doctor cannot go through all the EMR details every time, and he can enter wrongly some medicine which may affect the health of the patient. Our AI system can be integrated with the EMR, and it can, in the real time, stop the doctor that do not enter that kind of medication that can be harmful for the patient. This is the one example, and there are many other features which can be very helpful when AI will be integrated into the current AMR solution. The second example would be, we are currently working on the world first FDA-approved wearable ECG device. So currently what is happening, when the device is taking the ECG of the patient, it is transmitting the data to the mobile application, and that mobile application submitting that data to the doctor, who is actually manually reading the ECG, and then he is diagnosing and prescribing the medication over his whatever he sees over his diagnosis. Now, if we integrate AI into that in between, where doctor is currently diagnosing or checking the ECG, the AI system can do this automatically, and he can suggest, the AI can suggest either the patient needs immediate attention of the doctor, so it can send the ambulance, or through telemedicine, doctor can connect to the patient directly. So if we will integrate AI agents into this hardware monitoring system, healthcare hardware monitoring system with the patient and doctor, that AI can do the job of the doctor, the initial job of the doctor. So it can be make great impact as well. The third thing is that differential diagnosis tool. We are partnered with the leading differential diagnosis tools such as Visual DX. So we integrated that Visual Diagnosis. We launched that differential diagnosis tool here in Pakistan, and we saw a very good adaptation on AI on that tool. If you take a picture of your skin region, the AI image recognition system can recognize either it's psoriasis or eczema through the thousands of images which is already stored in the database of the AI. And doctor who maybe he cannot diagnose that this is the early stage of psoriasis, AI can detect it in a very early stage. So these are the 3-4 examples which I think, and this is already happening in the world. AI has been integrated. The question is, we are not only trying to implement and integrate these solutions currently within this Pakistan market and in Saudi and in Dubai, we are also taking care how the AI